Welcome to Dr Joe Unplugged. This podcast contains general information and is not in any way medical advice. All right, today it's my very great pleasure to introduce to the show Dr Brian Walker MLC. Brian, welcome to the show.
Thank you.
Thanks for coming on. We're going to get into some fairly controversial and I think topics that will be of great interest to the listeners. But before that, you're a member of Parliament. You're the leader of the legalised cannabis party here in WA. How have you gotten to be in Parliament? Just tell us a little bit about your background and what's led you to, and you're still practising as a doctor, but led you to where you are today.
Anger.
Focused anger.
Focused anger. Look, you're sitting in your clinic there, one-on-one with your patient, and they've got problems. All our problems that we see, at least in complex general practice, are actually, there's a lot of things going on. And most of it is actually out with our control. Here's a pill, but everything else is carrying on. And so many social problems were there, psychosocial issues arising, and I was powerless to deal with any of it. And I got so very angry because my patients were being bullied and harassed, and look, the workplace troubles there. So you can't fix that with a pill. You take a Valium and you'll sleep better, and I'll see you in a month's time. So we're actually just putting a plaster, a very inefficient plaster on a symptom and hoping they're going to get better. So in Parliament, I can deal with the bigger problems, have a larger audience, if you like, and maybe do something that's going to affect the wellness of society, not just the individual person.
And as from that, and also you bring to this experience from around the world. It's not like you've just worked in Australia in general practice. So can you tell us about a little bit of the journeyman story and some of the experience that's informed your views of the world?
Well, I left Australia when I was just about 16. I was going to volunteer for Vietnam. And my folks had been there, done that, said, nah, that's no good. So they took us back to their home in Scotland. So I finished school there and went to medical school and left as soon as I could. So I ended up worked for a short while in Scotland. The NHS was in those days, it was still quite a reasonable organisation, although there were lots of wrinkles. And then I went to Germany, spent 10 happy years in Germany with a very different style of medicine. After that, I went to Russia, the Soviet Union for a while, then back in the UK, much against my will. And then I thought, nah, I'm out of here. So I went to China and Hong Kong. And then, back in 2008, my wife says, it's about time you settled down. So I came back to Australia.
And look, I think we'll pick up on this a little bit later, but different countries do have obviously different medical systems, but also different cultural approaches to medicine. Ours necessarily is I suppose, an Anglosphere view, a very Western allopathic practice of medicine, probably largely derived from the UK and US systems, not necessarily as the system is run, but how we approach medicine. But in different European countries and certainly in different Asian countries, and probably in Africa as well, I'm sure in Africa, they have a different start point as to how they approach illness and how one can go about treating that. So, actually, maybe rather than do it later, maybe that's something we can chat about now, as how cultural backgrounds and different belief systems and how different societies operate might influence how diseases manifest, but more critically, how they are treated.
Oh, yes, there's such a lot of difference. You'd think for a simple medical case it would be the same whichever country you go to, but it's not. It's vastly different. In Germany, that's when I began to wake up. I was a typically classically trained UK graduate of medicine. And a very good education it was too. I was very, clinically you could actually do the things like a lumbar puncture or bone marrow biopsy. Fine, we'll do that, off you go. You did an apprenticeship on the wards, that was fantastic. In Germany, however, I began to be confronted by things I couldn't explain. For example, patients would come to me and say, I've got a urinary tract infection. I need some nettle tea. Nettle tea? And I said, yes, it is actually quite a useful treatment for ordinary urinary tract symptoms. And I thought, this is very strange. Or how about for sleeping? How about, what's it called again in English? It would be catnip.
Valerian.
Catnip, yeah, valerian, yes. And so I think, really? So I thought, what's going on here? So then a friend of mine says, I've got food allergies. I said, no such thing. Because back in the early 80s, no such thing. He says, well, that's where you're at, fine, but I've got food allergies. So I began to investigate these things. I realised that there was such a lot more I could learn. Then one day I left my clinic in Germany And I was in tears because for all the diagnoses I'd made that day, and I was a good diagnostician, for not one single diagnosis could I find an underlying cause. Well, for example, diabetes mellitus type 2. Fine. It's a relative or absolute lack of insulin. Right, fine. Why? Well, peripheral tissue resistance to insulin. Right, why? What's going on with that?
Yeah.
Rheumatoid arthritis is an autoimmune disease. Fine, why? What's the body fighting against? Oh, we don't know. Here, take an immune suppressant. Why? And so I left my practice in tears because I thought, I've wasted my time. I saved more lives as a surf lifesaver at City Beach than I have as a doctor. I was distraught. So now the good thing is Germany is very scientific. We had a book about yay thick, the red book, with all the herbal medications as well. All of them had been scientifically researched. Okay, the science. Look, Hahnemann from homeopathy was German. And the observation was there. Koch was German.
Yes.
The postulates came from there. And so all of the science that could be used, only a very small part of it had been used for the medical training. And that, of course, was the pharmacological science. Here's a problem, a diagnosis. There's a medication to fix, put a plaster on the symptom, and next patient, please. So that was just not fixing things. So my rheumatoid arthritis patient in particular was just deteriorating. We're hammering her immune system. The marrow was suffering, and she was very, very frail, young and frail. And I thought, I'm just doing no good at all here. So that started me on a pathway of investigating for myself. And I'm still on that pathway and realizing that our modern medicine, the allopathic that we've learned, as you mentioned here, the UK style, the American style, just doesn't give you wellness. And that's the point. We may have managed a disease to death, but we haven't created wellness. And that's where my passion is.
Look, and that's a very, very good point. Andrew Weil wrote a couple of books in the 90s, yes. Fascinating guy, and he had a line which I thought was very, very good. He said, if you need your appendix out or you've broken your leg, Western medicine is fantastic. And I 100% agree with that. He said, if you have essentially a lifestyle type condition, then Western medicine is not necessarily so good because, yes, they'll give you a tablet, but you think about it, with diabetes, with blood pressure, with a lot of these conditions, we're not fixing the problem. We're controlling it to the extent that as long as you take the tablet, you've sort of controlled it, but we're not really fixing it. And it could be fair to say some problems, they're not fixable, but probably a lot more are than what we do.
Well, we use language, Latin and Greek, quite a lot. We give a description for it. For example, let's take idiopathic pharyngeal erythema, which is basically a red throat. We don't know why. Blood pressure, idiopathic hypertension, which basically says you've got raised blood pressure and we haven't got the faintest clue why. Here, take a pill. Next patient, please. And this is fascinating. The appendicitis you mentioned, but the appendix is actually full of immune tissue. So what's happened there is there's been a response to something going on in the gut. The appendix has responded, and now it's become inflamed, and now we take it out. It's carry on ruining your gut. I can think of no other explanation for it. There may be others, but that's a classical one.
And look, it could be that when we think back to the discovery, not invention, the discovery of penicillin has been a very, very useful thing for people who do have bacterial infections, and we can treat those infections, whereas prior to that we couldn't. But that's also then been leveraged into, well, look, if that pill works, a pill must be the answer for everything. And I think doctors have been conditioned to that and society's been conditioned to that. And then to make it worse, government steps in and subsidises tablets and doesn't subsidise perhaps for diabetes or heart disease, doesn't subsidise gym memberships, it doesn't subsidise other ways that the problem or the issue perhaps could be addressed, but tablets are subsidised.
Well, indeed so. That's a huge problem. Take, for example, the antibiotics, as you've mentioned. We have in parts of the world where people would go to the doctor and say, I've got a headache. You'll say, here's an antibiotic, and then with other medications too. In Hong Kong, actually, it's very, very common. You're talking about transcultural medicine there. In Chinese culture, the doctors in the past would look at your tongue, they would feel your pulses, and they would know what's going on. So asking questions basically meant the doctor didn't know what he was doing. So you were not allowed to ask questions, otherwise the patient would say, this doctor is useless. So they'd come in, this is a 3-minute medicine in Hong Kong, you'd leave with 5 bags of pills, always 5 bags of pills for 2 or 3 days, come back in 2 or 3 days, and another 5 bags of pills. And they could be treating things which are entirely wrong, but here the patient felt as if they're being treated. because the patient didn't have to say anything. The doctor knew what was going on. Fix me, doctor. And of course, most of these are self-limiting illnesses. Of course they get better.
That's exactly right. If I give you a tablet and you get better, you may ascribe the improvement to the tablet, whereas in actual fact, you've just gotten better.
It's the placebo effect, isn't it?
Which, as work has come out with some of the SSRI antidepressants, that in mild and moderate depression, they've been shown to be no better than placebo. So people do get better. They say, I'm feeling better. That's fantastic. But what this data tells us is that they're feeling better because they're taking the tablet rather than because what the tablet might be doing.
Well, we also know that in 15 years' time, if you've seen your GP for the medication or seen a psychiatrist, the outcome's about the same. There's no different. And also, what I found fascinating in recent times is that the acknowledgement that most of our research is actually flawed, that the printed research we've got in our very esteemed journals may not be worth the paper it's printed on. And then with the SSRIs, you get the drug company, of course, will say, well, we've done 10 tests here, 10 studies, and 3 say it's good, 3 say it's bad, and 4 say it's indeterminate. We'll publish the 3 which says it's good. So the stuff which doesn't show that is then put to one side.
Yeah.
And we never hear about that.
Well, this gets back to the example before with the SSRIs, that at that time at least, and it may have changed now, I can't express an opinion, that to get your drug authorised by the FDA in America, you had to submit 2 trials that showed that your drug was better than placebo. And they did, and they showed that it was. But if you added back all the unpublished data and studies, that's where it became equal to placebo. So there's certainly capacity to game, as it were, the system.
Very much so, but there's also a downside. I don't know what you've been doing in your practice, but I always tell my patients if I'm giving that medication, and I don't like to, I'm saying in the first few days, you're going to feel worse. You're going to think I'm a quack. Here, take some medication to sort that out. And then later on, when they want to come off, oh boy, we've got a problem, because stopping it suddenly can give you very serious side effects.
Very, very much so. And I think that's starting to be a bit more recognised. I read a couple of weeks ago that in the UK they're looking at I hate the word deprescribing. It's just not taking medicine. It really doesn't need to have a fancy term with antidepressants. And David Healy, who's a psychiatrist, had a website. I don't know if it's still going or not. It was called Risk, but rxisk.org.
Yes.
And he would have a lot of information there about side effects of different medications and the problems people might experience with coming off them, which again is not to say for anybody who's listening you should stop your tablets without talking to your doctor, but it is to say that sometimes side effects are not well recognised and that side effects may be regarded as a new problem which needs a new tablet.
Oh, side effects, of course. Look, I remember this, some decades back, there was a problem with the contraceptive pill, at least in the UK, and it was reported there might have been 3 episodes of deep venous thrombosis and death from that over a year. And then the newspapers, they said, but don't stop your medication, consult with your doctor. Of course, the women stopped the pill in droves and, of course, fell pregnant. The number of women who died as a result of pregnancy was greater than the ones who might have died because of the contraceptive pill. So we've got this balance here of, are we doing any good? What harm are we doing?
Yeah. And your point about medical studies and evidence, I mean, look, we do learn and it evolves, but we hear so much from the powers that be about guidelines and what's called evidence-based medicine, and it's good. Look, it's a good idea. We should we should act based on evidence, but that fundamentally assumes that the evidence that we have is sound. And one big issue that has been identified years ago, but nobody seems too interested in it, by John P. Ioannidis, is the number of studies that are not verified. So you've done a trial or a study and you've made a finding, and that's good, but it's not really valid until you've been able to replicate it. Because if you can't replicate it, then there may be specific reasons why you got that finding that cannot be repeated.
Well, you know the gold standard, the double-blind, controlled, placebo-controlled, randomized trial is our gold standard, but the outcome of the trial is dependent upon the observer bias going in, which means that if an observer has this opinion about the medication, that'll be the result, another opinion, another result, which basically means that all of our studies so far are not actually valid, unless, of course, you can replicate them, and people find very often they can't. Our evidence base in medicine is actually very shaky, very shaky.
Yeah. And in addition to that is also, for example, say with high blood pressure, you do a trial on a new blood pressure medication, there are a whole load of exclusions for people who couldn't be considered in the trial, fair enough. But back in the real world, when they're coming in to see you or me or any other doctor, we're not necessarily prescribing to a person who fits the characteristics of somebody in the trial. So, yeah, well, we'll do this trial. Okay, this excludes people with diabetes, with asthma, with heart disease, with kidney disease, and. And the person who comes into the surgery may have quite a number, if not all of those conditions, and we are to assume that because it's been trialled in this particular cohort of patients that extrapolates. It may well do, but it might not.
Well, how about the problem we've got there? Most of our patients, at least if they're of a certain age, are going to have more than one condition, and often they have more than one medication. And there's adverse connections between one medication and the other, which you can probably map out. But if you get 3 medications, the potential interactions between 3 become uncountable. So things might happen which weren't predictable from that single test we've got there. And so I find when people come in, for example, in the wheat belt, when I was admitting patients into the hospital, one of the first things I would do was stop all the medication, and miraculously they'd often get better. But of course they need medication to start again because the symptoms return.
Mm-hmm. And the other point, talking about evidence, is, again, we hear from the various powers that be that, we need the evidence. And yet, when it comes to, I don't like the term alternative medicine, it's the one that's used. But again, in Germany, they seem to have evidence for a number of herbal formulations, which we don't have in Australia, and I think in America similar. But if the evidence is there, it's either there or it isn't there. How can it be there in one country and not in another?
Let me tell you about a particular herb, Mariendistel. What's that in English? Mariendistel, Silymarine. I don't know what the classical name is.
Oh, pass.
Anyhow.
Sorry.
But anyhow, this is actually a herbal medication which is good for the liver. Milk thistle, that's it, milk thistle.
Oh, right, yes.
Right. Anyhow, so there's a type of mushroom in Germany which regularly kills people. It's Knollenblätterpilz. I don't know the English for that, but it kills with periportal necrosis in the liver. And so this man was so convinced that this milk thistle was helpful, he took a large amount of the milk thistle and also a pan of the mushrooms, deadly mushrooms. And they tasted fantastic, he says, and his liver was absolutely fine.
Right.
He had no problems at all with liver failure at all. Now, it's a fairly high dose. Now, I've used that quite extensively. For example, cancer of the liver with liver failure, I've used this to actually prolong the quality of life very successfully. And I like it very, very much because it does a wonderful job in managing liver conditions. But it's a herb. You might then say, well, it's a herb, it's got no effect at all. Some of the best poisons I can mention to you are herbal. I can kill you very nicely. And my favourite natural medicine is actually the ACE inhibitor.
Yes.
Okay, because when the captopril first came out back in the early 1980s, it was derived from the venom of the Brazilian pit viper.
That's right.
Fantastic stuff. And what's more, it was given pure for hypertension. Right. On using it, we then discovered there's actually hormones at the cardiac level, which when you give it in congestive cardiac failure, radically transforms the outcome. That was so we'd only by discovering this through using the medication did we discover a whole different system of hormones.
Yeah. And look, there is sometimes a view out there that if it's natural, therefore it must be safe. And look, that's not necessarily the case. There's a lot of very, very nasty poisons out there.
Ricin would do you nicely.
That are quite toxic.
Oh yes.
But I think it is you spoke about observer bias, which is a real thing. But also it's where we're looking bias. So if we don't want to look for evidence, we won't find it. And I suppose that leads a little bit into a discussion about medicinal cannabis, which for people who know me, I'm a medical advisor to Little Green Farm, which is a medicinal cannabis company, so I need to put that on the table. Brian, you are the leader of the legalised cannabis party, so we put that on the table as well.
But you taught me about this many years ago.
And the same doctors who scream, yes, we need the science. I don't like the term "the science." I think that's lost its vogue. But we need science, we need evidence, and you present them with it, and no, that's not good enough. And yet, Just going to think how to phrase this. You know, there are certain other products that came onto the market in the early part of this decade that had far less rigour behind the trials, and the same doctors who said, no, there's no evidence for cannabis, were very happy to accept the evidence for this other product, which shall remain nameless because we don't want to sort of get barred from certain platforms. Well, I think people know what we're talking about.
Indeed so, and that was mandated, in fact, as well. So we're in deep doo-doo with that, are we not? But yes, I mean, the cannabis thing itself, I mean, just today, I was actually hoping to speak at the demonstration for the EPA. And there's a lady there who says, oh, Cannabis Party, no, we can't have you speaking here. So here, someone who's very much concerned with managing the environment and keeping us was actually of an opinion that cannabis is not going to be of any help in managing the environment. Well, we can turn the topsoil into a huge amount of topsoil. We can help with the waterways. We can manage with the microclimate simply by growing hemp or cannabis.
I mean, hemp as a building product and as a textile is very, as I understand, very useful in terms of the environment because it uses a lot less water, for example, than cotton. In fact, one of the stories, as I'm aware, that the reason hemp was prohibited is because the cotton farmers in the US didn't like hemp raining on their parade and had a lot of influence. And, again, the rest, as I say, is history.
Well, indeed. And so here we have someone who's actually passionate about the environment, completely unaware of the value of cannabis and hemp, and is of an opinion that this does not belong on the same platform as the EPA. And I'm thinking, wow, this is a wonderful example of the blindness, the conditioned by 90 years of propaganda.
And that, I suppose the worst part of that to me says that there is an unwillingness to actually be open to, well, maybe there's something that I don't know.
An open mind would be quite important. Because the whole point about science isn't that science is established. It's not. We need to ask the questions. Without a question, there can be no science.
Which, again, as we saw, this whole notion of believe the science is fundamentally flawed because you have to believe it. It's not science, it's faith. And if it's actually science and it's demonstrable and replicable, is that a word, replicable? Then you don't have to believe it because it is. Nobody has to believe that the sun comes up. It comes up. Nobody has to believe that in gravity because it just is.
Oh, we've got people now, I'm not sure if they're genuine or not, who actually believe the world is flat. I mean, but so the science, you have to question that. Let's find out, how do we determine the world is round? The science can show you that.
Look, if we didn't ask questions, we'd still be in caves.
Oh, absolutely. Maybe we still are in kind of metaphorical caves now.
Science literally, or human knowledge, can only advance by asking questions. And genuine science, and I think it's a quote by Karl Popper, there's a few people who've spoken about this, is the start point is that my fundamental belief is wrong and has to be proven to be correct, versus, I'm just going to do some work to show that I was right all the time.
Yes, indeed.
And that, unfortunately, I think the latter is more a little bit where we've moved to. And that also is funding. I mean, if you try to get government funding for a study that may go against the current worldview, you've got no chance.
I recall asking this is actually in politics, asking the Chief Health Officer about the data that had been given to Parliament. And he refused to give me the data, because he said it's cabinet in confidence. So A, as a medical practitioner, B, as a representative of the people, I was refused the information which guided the government to making its decisions, which meant that we're left in the dark. Mm-hmm. We are in the dark ages.
Yeah. Oh, yeah, I mean, as private doctors, if anybody wants to access their files or their notes, they put in an FOI request. In fact, usually they just ask and you don't have to go through that process because they've been given health advice and they have every right to access the information that sits behind it. If I'm a bureaucrat who happens to have a medical degree and I give advice that affects the whole population, meh.
Yeah, exactly so. And that's funny. This idea that people need to beg for their medical records. It's your body, your health. These are your records. You have them. And if I'm writing nonsense, then I need to be held responsible for that. So I don't have any problem in letting my patients see whatever I've written about them.
And I mean, with the My Health record, which is not a particularly useful tool, but if it does have one plus, patients can see their X-ray and blood test results, although unfortunately I think with radiology results often there's lots of words that most people, if you it's like a foreign language, may not necessarily understand, but they can still have it and then they can ask questions about it.
But then they can come
and
to
questions coming back to it is the key.
Yeah, indeed. So I get people coming and say, I'm terribly sorry, I've got a list. And I'm saying, yes, put your questions to me because it's really important we answer these questions. And if it takes 2 sessions, we'll do that. But you need to know what's going on because it's your health. I don't tell you what to do. I advise you what I think is in your best interests. You are the one who's got to take action.
Which also circles back to this notion that 75 to 80% of the disease burden in Western societies, it's not broken bones and acute appendicitis, it is lifestyle-related conditions, yes. Which in turn means that for people to be able to be better understanding of their body and how what they do to it influences what it does is an educational process. That all right, if I don't want to go down the path to type 2 diabetes, and again, there's never guarantees in life. Nothing's ever you can say absolutely it can never happen. But you can say, look, we can make it more or less likely, and you can make it less likely if you go down this path rather than that path.
I might get a bit controversial here by saying that the further away we come from living in accord with nature, the less healthy we become. One of the biggest sources of chronic disease, I think, is the gut. And so one of the biggest causes of chronic disease is, in fact, the food processing industry. And if you look at what's happening to our food, the chemicals we're putting into that, we're actually asking for problems to occur. I look at the amount of autoimmune disease coming, and I think, yep, okay, fine, there's maybe something in our environment. I look at the allergies, I look at the new diseases coming forward. I'm thinking, we must be doing something because we didn't have these before. And the more we've come away from living in accord with nature, now let's take cannabis as a source of that, as a wonderful, healthy, healing herb, which can be misused. Okay, and then look at how people grow that. Some people are using all kinds of chemicals. You don't want that. We need to have things grown nicely, cleanly, without added chemicals. Let nature take charge, and we use the nature. The same thing with how can we put this? What foods are we choosing? What are we walking barefoot, connecting with the life? Are we breathing properly? I had to show yesterday someone how to breathe properly, how to use their ribs to actually get the air coming down to the bottom there. We're just not living in accord with our demands as natural human beings.
Well, that's true. I think most people grow up thinking milk comes out of cartons and eggs also out of a type of carton. So there is that disconnect between our food and where it's come from, and restoring that I think is happening in little ways in different points, but not to an extent. A lot of people won't know, and I didn't before I got involved in the medicinal cannabis space, that up until the 1930s, cannabis was legal and was used in a lot of societies around the world and was a prescription medicine. And then it was banned, and it's an interesting story which we haven't really got the time to go into today. It might be another conversation. So it's not actually new. And yes, it can be misused, same as a lot of products can be misused. And with the food, you look at the pictures from the 1970s and up until the early 80s, we did not have nearly as many people who were overweight or obese then as we do now. And the big change was the introduction of low-fat dietary guidelines, which, as a paper in the BMJ about 7 or 8 years ago showed, get back to talk about evidence, we've got to have evidence for everything, no evidence to back the introduction of low-fat dietary guidelines.
Well, there's plenty of evidence to show that that is wrong. Ansel Keys, back in 1959, was it?
Yep.
The evidence he used to put forward to the American Medical Association was entirely false. He'd falsified the data to suggest that a low-fat diet would be helpful in reducing heart attacks. And therefore they said, OK, fine, we'll take the healthy fats out of our food. What did they use to put back into the food to make it tasty? It was sugars. OK? And we wonder why we're not as well as we were then.
Which comes back to understanding how the human body works and how different foods are processed within the body. In particular, that sugars cause the release of insulin, which is what it should do, but is the body's fat storage hormone. And if you're in fat storage mode, a little bit harder to lose weight.
Oh, yes. It's a huge problem. And the problem I've got with my patients just now, and I'm sure you do as well, is that when we ask people to go back to a normal diet, as a pre-1930s diet, because we're used to a very different so-called normal, when we go back to what really is normal, it's abnormal. So you've now got to go into an abnormal diet, because that's the way we should be living, but it's abnormal. And anything abnormal is difficult to do on the long term.
And people managed very, very well for hundreds, maybe thousands of years on what they in various ways could gather or catch. Could gather a little bit more than they could catch. But, in the 70s, people ate meat and three veg. Oh, no, you can't have meat and three veg. That's terrible. I think it looks like when you look at it, people were actually doing quite a lot better. And then you can have fish or chicken or vegetable proteins if you prefer. But that concept actually worked a lot better in the real world than what we're doing now with these processed foods that get variable. This is my favourite line, Brian. Ticks or stars or elephant stamps from some government committee that really wouldn't know which way was up.
The Country Women's Association, 1955, using lard for cooking. Fantastic. And I always tell my patients, you see that green tick of health and the thing? You do not get that. That's full of chemical stuff. Don't touch it.
Yeah. So we've sort of moved a little bit away from cannabis. I think we want to move back to this before we run out of time. So where have you seen the evolution of medicinal cannabis in this country, and where do you see it going, and what would you like to see happen?
When you first introduced me to cannabis at a meeting...
Notice how he keeps blaming me for this.
You should carry all the blame, my friend. Carry all the blame.
I'll wear it.
In those days, I was in trouble because I tried to get permission to prescribe cannabis on the SASB application pathway, and fighting my way through the government website, it was impossible. So I had to get Little Green Pharma to help me navigate that. You'd think I'm not that dumb, really, but I couldn't work my way through the paperwork of the government designed to make you actually go back to the beginning and start again. It was horrible. Now, since then, of course, things have changed so much. The opportunities we've got, the offerings we've got have been so vastly different. But also, we've got a lot of, well, not a lot. Those colleagues who are prescribing are producing a lot of information that you can spread among your friends who are prescribing. If you try this, think about that, do this. So the advice we're getting from our colleagues when we talk is actually much more refined than it was when I first began prescribing. And so now I'm very comfortable in looking at prescribing cannabis for autism and ADHD, as well as the usual things like your pains and your mental health issues. So it's the scene has changed so vastly. Initially, it was only psychiatrists can prescribe it, I think, or very few named doctors, and now anyone can prescribe. It's become much easier now, I think, to do that. But the problem I am facing, and this is my select committee when we were travelling through the Southwest and indeed through Europe and Israel, the one word which came out again and again and again from everyone everywhere was we need more education. Education of doctors, education of the public, as well as education of the politicians. That is critical.
Mm-hmm. And your committee made a number of recommendations, and we've got 12 months before an election in this state. What are your priorities in terms of those recommendations, and what do you see may well come to pass in the maybe short and medium term?
One of the joys I've had in being in Parliament is being able to stand up in the full public gaze and speak truth, science, facts.
Pretty rare for a politician, Brian. Well done.
I know, it's brought a lot of trouble to me. But do you know what? I have been blocked. The media is not reporting what I am saying because the narrative is controlled by the government and they don't want this information to come out. For example, driving with THC. Oh, it's a dangerous thing. You're impaired if you have THC positive. That is a complete and utter, bald, barefaced lie. We have lies enshrined in law and we're supposed to abide by that. So when I speak to the truth in Parliament, you find this closed shop. Oh, we can't talk about this. Oh, no, this is all wrong because the law says. Well, the law is a ass. And so one of my pleasures is getting up to actually talk truth to the matter. And as I'm a practicing doctor, as I'm still at the front line, as I'm still a specialist in that area, when I speak, they can't really shout at me and say you're talking nonsense because I'm doing it, they're not. I'm experiencing it, they're not. These are the results I'm seeing on a daily basis. And one of the pleasures I get, I'm sure you do as well, my cannabis patients coming in, they're smiling, they're saying, you have restored quality of life, I can live again. And that's probably the first time I've had that experience. Well, a few examples otherwise. But on a regular basis, my cannabis patients are thanking me for saving their lives and saving the quality of life. And then when you see that the government is trying not to allow this to become generalized in the public, why? Because it's a dangerous drug. Here, have some more heroin. We can give plenty of opiates, but it's dangerous. How many people have died because of cannabis last year in Australia? 0. How many people died of opiates last year in Australia? About 800. Why are we comfortable giving one but not giving the other? So I ask these questions in Parliament, and their faces are all blank. They don't dare say anything because, I know I should be agreeing with you, but I don't dare because my big bosses are saying this is bad. And it's fascinating to watch. What I've discovered, of course, is that truth in politics is utterly unimportant. It's the perception of truth.
Yeah, I think that might have been the case for a long time. So you're breaking the mould there, which is really good. Look, I think a couple of points I think are important. Number one, medicinal cannabis, like every other medication, nothing works equally well for everybody in all circumstances. True. But yes, when it does, and certainly I've seen the same with some people, they really have a significant improvement in their quality of life. And these are people who by necessity in this country have been on a whole host of other treatments previously.
Indeed, but for some people it doesn't work at all.
Yeah, that's very, very true. And we should increasingly see it like any other medication. There is not a blood pressure medication on the market that lowers everybody's blood pressure. There's not an asthma spray that works for everybody with asthma. That's why we have more than one. But the THC, and obviously nobody should drive impaired for whatever reason, but there are antihistamine medications you can buy over the counter that have the potential to cause impairment. Detection of THC is sort of essentially like you're at less than 0.01 alcohol, like you're 0.001, but because it's been detected, it's deemed that you're impaired. And that really is the nut that hasn't been cracked.
Well, that actually came from, I think, 2016, when cannabis was still declared an illicit substance. So if you've got presence of THC, obviously you're taking an illicit substance, and therefore we're going to deem you as being impaired. Completely wrong, of course, but I can see why they're doing that. But did you know that the government actually allows us to drive while impaired?
Oh, yes, if we can waive a prescription for an opiate or a benzo.
No. Okay. You go with 0.048 alcohol in your system, you're not deemed to be impaired, but you've got about a 3 times risk of having an accident than someone who's had no alcohol. Okay. So we're allowed to drive with a 300% increased risk of an accident, and we're deemed to be okay. Now, I've got the figures actually for cannabis. If you are impaired, it's about 1.5 times you've got a risk of an accident. Now, I always say you should not drive when impaired. That's absolutely clear. Absolutely. But why is 300% increase deemed okay and 150% increase is deemed not okay? What's the science behind that? Has anyone asked the question? The answer is, if they've asked the question, they've covered their eyes to the truth. And this is really quite sad. We need truth.
I think there's also that issue that typically questions aren't asked if the answers aren't wanted.
Well, and also the questions are only asked if you know the answer. Now, we actually have asked the question before. We asked a question without notice and said how much positive tests have been discovered in people who were driving and had a fatal accident. And it was about 29 out of 128 deaths. Okay, shot in your foot. But then we asked questions on notice, so that's a much more detailed one, for the 2 years. About 125, 129 deaths roundabout in those 2 years. That's a lot of deaths. We shouldn't have that in the first place. Of all of the accidents, 1 year there was just cannabis. Of all the deaths, only 2 had cannabis in their system, and that wasn't declared the cause of the accident. It was just present. But there was, for those 2 years, there were 6 pages of drugs detected in the post-mortem examination. 6 pages, including ketamine and fentanyl, and indeed propofol as well.
Yeah. So there's a whole host of prescription medications that can impair your ability to drive, and including some over-the-counter medications. But yes, cannabis is singled out.
And of all those fatalities, 70% had alcohol in the system.
And we say with detection, it's similar when there are overdoses. They're probably the ones people hear about the most, of the celebrity overdoses, and the toxicology can be a list as long as your arm. But that, in those situations, cannabis is detected, does not mean that that is what has caused the death. There's usually opiates, and could be ketamine, could be fentanyl. Matthew Perry, possibly the most recent one that comes to mind. And from memory, and I could stand corrected, I think one of the substances found was THC, but that is not what's caused it. It's just there, but it's not the cause.
If you take the individual substance, the cannabinoids, let's just take all the 85 cannabinoids, just make it one THC. That's the one people are concerned about. How many people are killed by THC in the world? And I think the total answer is 0, isn't it? You get more people gored to death by unicorns than killed by THC. But if you then mix it with other things, take alcohol, for example. I gave a speech the other day there when I said it's the third drink causes the problems. The first two, you're okay. By the third drink, then things happen. Now, when you then start taking other things with the alcohol, yes, you might have some cannabis, but then the other drugs come into play, the benzodiazepines, for example, because I'm very stressed, I'll have a Valium as well. Now, mixed with alcohol, you have a whole mess of problems. So what we're looking at here is the complex interplay of all that we're taking in a recreational basis. And if we just focused on let's use cannabis rather than alcohol, would we be safer in society? Yes, hell yes. Would we have the violence in Northbridge? No. Would we have the car accidents? No, we wouldn't. So let's open our eyes, ask the questions, and get some proper science out there. What is the actual problem?
Yeah, and I think that's another thing the government doesn't want to look at is that the one-punch assaults are fired by methamphetamine, and people use methamphetamine because it gets out of their system more quickly versus cannabis. So if they're drug tested on return to work, it won't show up. I don't see too many one-punch assaults from people who have had cannabis.
Well, what you're getting with cannabis in Northbridge is going to be an extra sandwich or an extra piece of fish. You know, that's what you're getting. You're not getting a punch in the face. And also, there's this methamphetamine. This has been driven, if you like, by the FIFO industry saying well, any THC and you're out. The methamphetamine is now taken off. So we're actually the capital of methamphetamine.
The meth capital.
Indeed. But what then happens is out of your system. But you had 7 days of a binge. You're now sleep deprived. When you are sleep deprived, you have the same impairment as if you got 0.08 of alcohol in your system, and no one cares.
No. So what are your 3 priorities for the next 12 months in the lead up to the next state election? Because it's probably, I imagine, in the political cycle, the best time to try and get something done. Correct me if I'm wrong.
Well, of course, we're putting our legalised cannabis amendment bill coming in, the misuse of drugs amendment coming in March, probably. That's a given. But I want to expand what we're doing. People think we're a single issue party. We're not. We're a wellness party, physical, mental, social, financial wellness and social justice. And so I'm putting information out there about, say, the health system or the sickness system, as I call that. We've got to fix that. We've got to fix the environment. So the ecological issues, the sustainable environment, the regenerative agriculture, restoring our world, if you like. That's an important part of what we're doing. Then the criminal justice system. You've talked about the youths in prison just now, the fetal alcohol syndromes. You've got the mental health issues they've got. You look at how they've been raised as children, the deprivation they've gone through, and what they've been exposed to. Is it a wonder that they're actually giving us a hard time? Are we actually, with our punitive system, are we actually helping to regenerate and help cure these people? Or are we actually making the cycle worse by punishing them? And the answer, of course, is obvious. So why do we continue doing the same thing to make things worse? And that's what I want to be working on in the future.
Sounds good. Brian, we've touched on quite a lot of stuff, quite a lot of topics today. Some we've gone across the surface. Thank you so much for coming on the show today, and I look forward to having you back to maybe spend a whole session just on in any one of the half a dozen topics that we've spoken about today. Thank you so much.
A real pleasure. Thanks for the invitation.
Thanks for listening to Dr. Joe Unplugged. If you enjoyed this podcast, please subscribe, like, and share. You can also follow it on all the socials. There'll be new content uploaded each week.